New research shows the only antiviral drug with emergency authorization to treat COVID-19 in the U.S. does not actually help patients. A study from the World Health Organization found remdesivir, quote, only appeared to have little or no effect on hospitalized COVID-19 patients, as indicated by overall mortality, initiation of ventilation, and duration of a hospital stay. Dr. Annalee Baker joins me now. She's an ER doctor at NYU Langone and a professor at the NYU Grossman School of Medicine. Now, Dr. Baker, what's your reaction to the World Health Organization saying this treatment may not be working? I think it was, hopeful for some people that we had some things that were working, but this is the only one, and now they say it doesn't.
Thank you for having me, Savannah. Yeah, it is a little disappointing to hear these initial findings. I would caution everybody that this has not been peer-reviewed yet. So this data was released on Thursday. It's a massive trial, 11,000 patients in 30 countries that received actually not just remdesivir, but several other antivirals, hydroxychloroquine in different combinations. And they looked at some endpoints that are much more important to us clinically. They looked at reduced mortality. They looked at the need for ventilation. These are endpoints that actually matter. So the earlier data that had suggested that there might be a benefit to remdesivir had only really shown that there might be a decrease in the length of the illness, which practically speaking doesn't really matter if the endpoint is the same, if that makes sense. So it is disappointing, but I would caution just to wait until the peer-reviewed journal article out to really make conclusions from this. I think it's just too early to say that it's not effective for everyone.
Now, Dr. Baker, may I ask, as an ER, what your experience with remdesivir has been like so far?
Well, I have to tell you that remdesivir, when it first got the emergency use authorization, it was in May, and it was only authorized for patients who were very sick and requiring oxygen support in the hospital. So for the most part, early on, we didn't start remdesivir in the emergency department. It was started up in the ICU once the patient was intubated, usually by us, upstairs, stabilized in the ICU. So I didn't have a lot of experience with it. Later in August, they expanded the use of remdesivir for anyone that was hospitalized. In other words, we were able to give it to more patients. So I had a little more experience then. None of us have really noted a dramatic effect, but it's very difficult to figure out what the effect is because there are so many things that go into caring for a patient, and that is the other thing about this WHO trial that occurred across so many different hospitals, 400 hospitals in 30 countries. You have to imagine there were other variations in how these patients were cared for. So it's hard to say exactly what was having an effect, but no, I have not seen remdesivir dramatically affect anyone.
Now, let's talk about another drug, hydroxychloroquine. This same study found it didn't have any benefits for COVID patients. It was one of the first drugs we heard about. It's an anti-malarial drug that President Trump himself has taken. A lot of research has shown it's not good for COVID, but what does it mean now that the World Health Organization is officially saying it doesn't work?
Well, I think with hydroxychloroquine, we're pretty much there. We've got the answer. I don't think hydroxychloroquine is doing much for anyone. The idea with hydroxychloroquine is that it's an immune suppressant. So we know that in some of the patients who get very ill with COVID-19, the problem is not necessarily the virus itself, but this immune dysregulation or this cytokine storm that you've probably heard of. So that's why hydroxychloroquine was presumed to be potentially effective because it does suppress system and it's used in autoimmune conditions. But in COVID-19, we have not seen very promising results either in the, people that are out and taking it, not hospitalized, or in the critically ill patients. So I think this just supports what we already knew and what the other papers have shown.
All right, Dr. Baker, thank you so much for joining us.
Thank you for having me.